We are going to talk about the inherited and acquired cystic kidney diseases. Now, many things can cause cystic disease in the kidney. Sometimes inherited conditions may lead to cystic diseases like autosomal recessive or autosomal dominant polycystic kidney disease. Sometimes cancers present as cysts. Sometimes it's acquired. For example, patients on renal dialysis for years, their kidneys become somehow cystic. Okay, so sometimes it's congenital. Some newborns are just born with this multicystic, dysplastic kidney. So there is no a single cause for renal cysts or cystic kidney disease, and it's quite common. Now let's start with the inherited causes. Because they are quite common, the autosomal recessive and the autosomal dominant polycystic kidney disease. Now, actually, regarding autosomal recessive and autosomal dominant, they have different mutations on different genes, and the mutated proteins, the abnormal proteins in both of these diseases are different, okay? And so autosomal recessive gene is different from autosomal dominant genes and proteins being mutated. Now, because it's autosomal recessive, regarding autosomal recessive polycystic kidney disease, because it's of its autosomal recessive inheritance pattern, the risk of inheritance in the family with autosomal recessive is up to 25%, like any other autosomal recessive disease. Now, the gene mutation is called PKHD1 gene, and this mutation will result in abnormal protein, very important from the tubules of the renal tubules protein. We call it fibrocystine protein. Okay, so this protein is present in the renal tubules. That's why when we have mutation in this protein, it will end up in having cystic diseases of the kidney. If you look at this newborn, if you look at the kidney size, they are massively enlarged, bilateral, and actually we don't see the cysts here from the outside, but if you open and do cut sectioning of the kidney surface, you will be able to appreciate the multiple numerous renal cysts. Now, because of this process starts very early in life, in intrauterine life, the fetus of autosomal recessive polycystic kidney disease will be not able to form urine. And that's why the mothers of these patients will having oligohydramnios. What do you mean by oligohydramnios? Oligo means small amount of amnion, which is the amniotic fluid that surrounds the baby in the intrauterine life. And why is the amnion is important? The amniotic fluid, we need to have adequate amniotic fluid around the baby because it's very important for the development, especially of the musculoskeletal system. The baby needs to move his parts for a good maturation of the musculoskeletal system. In addition, this amniotic fluid is associated with lung maturation. So it's very important to achieve lung maturation of the baby. Now, if you look at this patient over here, and if you look at the lung, actually he has very, very ultra short, small chest. So very, very small chest because of the hypoplastic atrophic lung. There's no lung maturation whatsoever because of this oligohydramnios, because of this renal failure in this patient. Now, if you do cut surface for the kidney, it's actually the kidney is enlarged in comparison with the size of a newborn kidney. It's enlarged, it's of large size. And the surface is actually replaced by multiple numerous small cysts. The whole surface, especially the cortex, contains a lot of small cysts of variable size. Now, again, the fibrocystine protein is that results from PKHD1 gene mutation in 25% of the family members. Now, this fibrocystine protein is not only present on the renal tubules, but it's also present on liver ducts and also pancreatic ducts. That's why patients with autosomal recessive polycystic kidney disease with this mutation will have pancreatic fibrosis and congenital liver fibrosis. So the problem will also affect other organs, including liver and pancreas. if we look at the kidneys under the microscope, here we can see the cysts. They are actually variable in size from very small that we cannot appreciate them grossly to large cells that they were visible grossly at the cut section of the kidney. Most of these cells are actually radially arranged. They have this radial arrangement toward the center or towards the hilum of the kidney. They resemble spokes of a wagon wheel. So they resemble the spokes of a wheel. That's why because of this radial horizontal arrangement. If you look actually between the septi of these cysts, you can see few glomeruli. So you can appreciate few residual glomeruli and residual kidney tissue, but unfortunately these are not enough to maintain adequate kidney function test. So going back to a liver biopsy from the same patient of autosomal recessive polycystic kidney disease, and as we have said, because of the mutation involving fibrocystine protein, they will have congenital liver fibrosis also. And here we can see the fibrosis in the periportal area mainly, and here we can see the abnormal proliferating ducts radially arranged around the fibrotic area due to this mutation involving the fibrocystine protein. Now, moving to the autosomal dominant polycystic kidney disease. An autosomal dominant, because it's inherited in autosomal dominant fashion, family members at 50% risk of having this disease because of this mode of inheritance. The second thing, the manifestation will start actually at an adult age group, not from the pediatric, not from the newborns. So they will start to have a manifestation of abnormal kidney function test, of renal failure, of hypertension, and sometimes they present with bouts of hematuria due to rupture of these cysts. So the manifestation will start at adulthood. And here we can see the wrist bilateral enlargement of the kidney. Actually, the average longitudinal axis of the kidney is around 6 centimeters, and here it's more than 15 to 20 centimeters. So their kidney is quite huge because it contains numerous large cysts filled with urine. And here we can see some of the cysts from the outer surface. It's actually erythroperitoneal organ. They're present at the end, beyond the peritoneal cavity. Now this is the cut surface of the left kidney from this patient. You can see there is no healthy renal tissue at all. It's all is replaced by small cysts. And as a mode of treatment, initially they may undergo renal dialysis. But later on, what we do for these patients is to find a good donor and to do a kidney transplant. And here we can see transplanted kidney in this patient. Look at the healthy transplanted kidney. And compare the size and the appearance of this normal healthy kidney with the appearance of the large size and the cystic appearance of the autosomal dominant polycystic kidney disease patients. Now this is again a cut surface from the kidney. You can see it's all replaced by multiple cysts filled with urine. It's usually heavy here in this patient, it's 3 kilograms. Usually there occurs calcification and crystallization within the cysts and within the tissue, and specific type of crystals, we call them oxalate crystals or oxalosis. So oxalate crystals, actually, if we do microscopic analysis and examine their urine under microscopy, we can see the oxalate crystals under the microscope. Here, for example, this is the urine test, and this is the microscopic urine analysis. And here, under the microscope, you can see the oxalate crystals. Now, sometimes you can see RBCs, but in this patient, there's no RBCs, but sometimes we can see them. Here in their blood, it's actually their urine, there's some few amount of blood, there's no proteinuria. The other characteristics of the urine is normal. So he's having just mild hematuria. But if you do kidney function test, it will be all the functions. The urea will be high, so the creatinine will be high. So if you do check their blood pressure, it will be high. So the kidney function test is actually abnormal. Now we said we may see acquired conditions that lead to acquired cysts in the kidney. The most common cause for having acquired cystic disease is renal dialysis. Renal dialysis associated cystic disease. Now, whatever the underlying cause that lead to renal failure for patients, so if he's having diabetes and as a complication he's having renal failure and put on renal dialysis, or hypertension or glomerulopathy, lupus nephritis, whatever was the cause, these patients who are put on renal dialysis for a long period, chronically, they will have a risk to have acquired cystic disease in their kidney, like this patient. So the kidney is of normal size, however, there is multiple small cysts replacing the kidney tissue, which was initially abnormal and non-functioning from the beginning. Now, what's the problem with this cystic disease in these non-functioning kidney? The problem is that they are highly associated with developing renal carcinoma. This is the problem. They are at high risk of having renal cancer. If you look, this is acquired cystic disease from a patient who he is already having renal failure. But if you look here in the center, there is a big solid mass with area of necrosis and hemorrhage. This is actually high-grade renal carcinoma on top of acquired cystic disease. That's why patients on renal dialysis, you have to carefully check their kidney and examine their kidney and be careful to follow them up, not because of this risk of having cystic disease and cancer later on. We don't remove them because we don't want to put the patient under the risk of surgery. We don't want to do open surgery for the patient just to remove their kidneys. But if we suspect there is a small mass, or if we suspect that there is a small mass and if we are following him, we can just detect the mass from the beginning and just remove their kidneys, okay? Now, in addition, it's not easy to perform surgeries, especially if the patient is diabetic and hypertension and elderly. So sometimes you have to look at the whole full picture of the patient, if he can tolerate a surgery or not. Okay, so in addition, it's not uncommon to find just simple renal cysts. If you do for yourself, or just do ultrasound for any pregnant patient, or do MRI or abdominal CT for whatever reason for a patient, it's not uncommon to see just incidental finding, a simple cyst, benign cyst in the cortex. It's actually up to 10% of the population having these benign simple cysts. Now, how to know that this is simple benign cysts? Usually solitary or few cysts in the cortex, incidental finding. The patient is having no symptoms, the kidney function is normal. So we actually do nothing for them. We let them there, and we reassure the patient that these are benign cysts and you don't have high risk to, for example, renal cancer. You don't have a risk to develop abnormal kidney function test, so or end-stage renal disease. So just what we do is reassurance. Now, moving to our main topic, which is glomerulonephritis. Now, before talking about glomerulopathies or pathology of the glomerulus of the renal tissue, we have to know what the normal glomerulus looks like, okay, and what's composed of. Now, actually, this is a normal, completely normal, healthy glomerulus. Here we can see it's composed of multiple capillary loops, tufts of capillary loops, okay, attached together. Stay within a space surrounded by this capsule. What do we call this capsule? The Bowman's capsule, okay? So we have here from the outside the Bowman's capsule, and from the inside we have these capillary loops, tufts of capillary loops attached together within the Bowman's capsule. Now, the capillary loops, what's the type of cell lining from the inside of the capillary loops? Endothelial cell, okay? From the inside, it's endothelial cell. And from the outside here, what do we call these cells from the outside the capillary? No, from opposite to the endothelial cells. They are the podocytes, the epithelial cells, okay? Yes, there is basement membrane between the two cells. Between the endothelial and the epithelial cell, we have basement membrane here. So imagine this is the endothelial cell, and from the outside we have this epithelial cell. We call it, the other name for this cell is podocyte, and in between we have a basement membrane. Now the mesangial cells, they are the supporting cells that are supports the capillary loops together, and they also act like macrophages, the mesangial cells here in between. So we have endothelial, mesangial, and epithelial cells. In addition, at the Bowman's capsule here, what do we have? Another type of epithelial cells, other than the podocytes. We call them parietal epithelial cells, okay? So we also have epithelial cells at the outside rim of Bowman's capsule. Now, if you look outside the glomerulus, here we can see renal tubules. We have, we have the renal tubules, the proximal convoluted tubules, the distal tubules, etc., collecting ducts. All of them, we can see them outside the glomerulus. And they are lined by a single epithelial lining. So this is the normal cellularity and normal appearance, normal basement membrane of a glomerulus. This is what a good glomerulus looks like. We can do special stains to highlight the basement membrane and to examine specifically the basement membrane, like this stain, the PAS stain, and we also highlight the basement membrane in pink, red line. And we can see, is it of normal thickness, is it thickened, okay? So we can check for the thickness of the basement membrane. Another special stain that's better than the PAS is also the silver stain. And the silver stain, the basement membrane will be black in color, okay, not red. The same thing, but it will give us a black discoloration of the basement membrane. Now, if you look here at, this is a diagram to just closer look, to give us a closer look at the glomerulus here. You can see the capillary loops. This is a capillary loop. This is a second one and the third one. From the inside here, we have, this is the endothelial cell. This is the nucleus of the endothelial cell, and this is the cytoplasm. Sorry, this is the cytoplasm of the endothelial cell. What is the cytoplasm? There is what? Fenestration. Okay, there is fenestration to permit a good filtration of blood. So after the endothelial cell, we have the basement membrane. This is the basement membrane, normal thickness. And then opposite to the endothelial cell from the inside, from the outside, we have, this is the podocyte or epithelial cell. This is the nucleus of the podocyte. And this is the cytoplasm. And the cytoplasm have these specific processes. They should be short and thin. We call them foot processes. Okay, so this is actually the barrier, the blood barrier that is very important for the filtration barrier at the glomerular basement or at the glomerular filtration barrier. Now here, supporting these three capillary loops together, we have mesangial cells. We have two mesangial cells, and the mesangial cells also produce a matrix, mesangial matrix, to support the loops together. This is very much resembling what we see under electron microscopy. We do electron microscopy in the glomerulus to look for ultrastructure of the capillary loops and to check for pathologies of the glomerulus. This is actually from a patient who is suffering from nephrotic syndrome. Now, what do we mean by nephrotic syndrome? Usually we divide the patients who come complaining of renal glomerulopathies to nephrotic patients and nephritic patients. Nephrotic are the patients that come from edema, complaining from edema. Generalized edema starts in the periorbital area mainly, and then become diffuse and generalized. And if you check their urine, they will be having proteinuria, loss of protein, especially albuminuria of albumin type. And if you check their blood, they will be having hypoalbuminemia because it's lost in the urine. They will be having hyperlipidemia and many other things. So this is what do mean by nephrotic syndrome, okay? So this is electron microscopy from a child who present with nephrotic syndrome with features of edema and buffness. So here we can look at the capillary loop at the bottom. These are actually RBCs within the capillary loop. And here we have the endothelial cells and the fenestration of the cytoplasm. So this is the fenestrated endothelial cell. And after the endothelial cell, we can look at the basement membrane. What do you think about this basement membrane? It's actually normal basement membrane. It's regular thickness, looks normal. There's no deposits along this basement membrane. Now we want to look at the epithelial part or epithelial side. If you are looking here at the foot processes, you can notice that these foot processes are not short and thin. They are actually effaced and flattened and look as if they are fused together, okay? They are not actually fused, but they are actually, there's no space between them, so they look as if they are fused. So here we have the effacement of the foot processes is the only finding in this patient. And this is what qualifies for minimal change disease. Now, why do we call it minimal change disease? Because the changes are not evident, but only under electron microscopy. So if you do H&E stain, it's normal. If you do immunofluorescence, it's negative. If you do BS, silver, so everything looks normal. But if you examine the glomerulus under electron microscopy, you can see this effacement of foot processes, okay? So this is the only finding in minimal change disease. Now, actually, minimal change disease is the most common disease that lead to pediatric nephrotic syndrome. So if a child presented to you with nephrotic syndrome, the direct diagnosis is mostly minimal change disease. We directly give them steroids even without biopsy, and most of them will respond good to steroids, and their renal function, their urine test, everything will come back to normal. So it's a good disease most of the time. Most of the patient will respond good to steroids. So this is the urine analysis from this patient with minimal change disease. So the only finding is proteinuria. Urine, microscopic urine analysis, everything else is normal. Now, another cause for nephrotic syndrome, not only in pediatric age group, but also in adults, is this disease, what we call focal segmental glomerulosclerosis, or FSGS. Now, why we call it focal? Because only focally the glomeruli, part of the glomeruli are involved. So there is a portion of the glomeruli that they look completely healthy and normal. Only focally the glomeruli are affected. Why we call it segmental? Because not the whole glomerulus is affected. Only a segment of the glomerular tuft is affected by sclerosis. Now, if you look here, the top segment of this glomerulus is sclerotic, while the bottom segment here, it's normal. There's no sclerosis, there is no deposition of collagen. What do you mean by sclerosis? Scar formation or collagenization or collagen deposition within this segment matrix, and also here there is a scar at the Bowman's capsule. Now, to look for collagen or to confirm that this is collagen, we can do trichrome stain. In trichrome stain, the collagen will look blue in color. So here we can see the segmental sclerosis of this glomerulus. If you look to the right side, the glomerulus is actually healthy, normal. There's nothing within this segment. But only the left side of this glomerulus, there shows segmental glomerulosclerosis. And actually, it's focal segmental glomerulosclerosis is responsible for a sixth of cases of nephrotic syndrome in adults and children. Sometimes, in addition to nephrotic syndrome, they may have some level of hematuria, some blood. Sometimes they have also hematuria in addition to nephrotic syndrome, but the main presentation is actually nephrotic syndrome in adults and in pediatrics. Now, this is another glomerulopathy here. What do you notice first if you look at this glomerulus? What's the first thing that you noticed? It's crowded. Yes, it's cellular. We call it cellular. There is hypercellularity. It's much, much more cellular than the normal glomerulus we saw it first. So here, another thing, where's the capillary loops? You cannot see all of the capillary loops are what? Are occluded, are obstructed. Now, usually the cause of capillary loop obstruction is endothelial cell proliferation. So that's why we do not see the lumen of capillary loops, because of the endothelial cell proliferation. In addition, if you look at the mesangial area, there is also mesangial cell proliferation. And if you look at the podocytes here, the epithelial cells, there is also row of podocytes. So we also have epithelial cell proliferation in addition. Now, if you look closely at the glomerulus, we can see also these cells. What are these cells? Neutrophils. So they are polysegmented cells. They are actually the neutrophils. So in addition to mesangial, epithelial, endothelial cell proliferation, we also have leukocytes and neutrophils. This hypercellularity with the presence of neutrophils is a characteristic finding in post-infectious glomerulonephritis, okay? So this is diagnostic of post-infectious glomerulonephritis. Now, why do we call it post-infectious? Because the patient usually had history of upper respiratory tract infection with specific group of streptococcus, which is group A beta hemolytic streptococcal infection, mainly to the pharynx. And after a month, at least 3 weeks, 3 to 5 weeks, they present with hematuria, hypertension. And if you dig in the history, he will tell you, yes, in the past month, and I had upper respiratory infection, and I took a course of antibiotic, and it was resolved, and everything is fine. Until today, I have hematuria and hypertension. So it's actually caused post-infectious because it's not directly caused directly by the streptococcus infection. It's indirect process due to accumulation of antibody-antigen immune complexes, okay, that was there due to activation of our immune system. There is an antigen-antibody complex formation, and this will become entrapped at the glomerular basement membrane. And this entrapment will lead to this irritation of the glomerulus and hypercellularity, and it is the cause for nephritic syndrome in this patient. So that's why we call it post-infectious glomerulonephritis. Now, if the patient does not remember or does not know what type of infection he had, we can do a blood test for them. We can check for the antibody against the streptococcus, what we call anti-streptolysin O antibody. So if it is positive, there is evidence that this patient had been infected with streptococcus, okay? Also, to look for the deposits, always, if we want to look for glomerular deposits, we have to perform immunofluorescence. Okay, immunofluorescence is an excellent method to highlight the deposits along the basement membrane. We can do immunofluorescence for IgG, IgM, IgA, fibrinogen, C3. So we control what to look for, what type of deposits we want to look for. In this patient, this is an IgG positivity in post-infectious glomerulonephritis, shows the IgG deposits along the basement membrane. So here, this is a basement membrane positivity. We can see the capillary loops. They are positive, they are bright green in color. And it's a granular positivity because we have some small granules, some large granules. So that's why we call this positivity granular positivity. Sometimes we have linear positivity in other diseases, but in this disease, it is a granular basement membrane positivity. Now again, we can see the deposits under EM, under electron microscopy. Now this is actually the capillary loop here. In this capillary loop, we have a neutrophil. So this is actually neutrophil in the space, occupying the space of the capillary loop. This is the nucleus of the neutrophil. And here, after that, we have the basement membrane. Now, within the basement membrane here, at the epithelial side, we have this deposit, okay? So it's thin basement membrane. Suddenly, we have this deposit. So this is a deposit as the subepithelial area. This is characteristic. This is what we find in post-infectious glomerulonephritis. At the bottom, we have another EM picture. Here we can see this is the capillary loop. These are the endothelial cell proliferation, fenestration and endothelial cell. This is the basement membrane. Again, we have here deposit at the subepithelial side. So we have this subepithelial deposit. This is characteristic in post-infectious glomerulonephritis. Now we said what is the most common cause for nephrotic syndrome in pediatric age group? Minimal change disease, okay? So in pediatric, it's minimal change disease. But in adult, what's the most common cause for nephrotic syndrome? No, it's not focal segment. In adults, it's membranous glomerulonephritis. So membranous glomerulonephritis, it's the most common cause for nephrotic syndrome in adults. Why it's called membranous? Because as you can see, the only pathology is within the membranes. They are quite thick and thicker than normal. And there's no hypercellularity. So the only finding is the thickening of this membrane due to deposited immune complexes at the membrane, within the membrane, and that's the cause for nephrotic syndrome and loss of proteins. Now, regarding membranous glomerulonephritis, can be primary idiopathic without any underlying cause, but sometimes it can be caused by certain infections, malignancies, immunological diseases. So many other diseases can lead to membranous glomerulonephritis, like hepatitis B, carcinomas, like lung carcinomas, SLE, and many other things, may secondary lead to membranous glomerulonephritis. Because it causes nephrotic syndrome in their urine analysis, the only finding is a significant amount of proteinuria. Here it's 4+. The other findings are normal. Now, to look for the membranes, we said we can do special stain. We call it silver stain, okay? And the silver stain, the membrane should be black line. And here in membranous glomerulonephritis, if you look at the membranes, they are interrupted. There are dots adjacent to each other. It's not a single black line. And here we can see the dots, black dots, numerous black dots adjacent together. We call these dots, we call them spikes, okay? So here at the silver stain, we can see the spikes. If you look here, multiple spikes adjacent to each other in a membranous glomerulonephritis. And this is diagnostic, actually, of membranous glomerulonephritis. These spikes are basement membrane material, and in between them, we have immune deposits. The immune deposits are not are negative for silver stain, so the immune deposits will not stain black on silver stain. They are negative. That's why they will appear as pink to yellow here in between the spikes of the basement membrane. Now we can also do immunofluorescence to look for the deposits. This is the IgG immunofluorescence. So we have diffuse membranous positivity, again granular positivity of variable intensity along the basement membrane due to deposits within the basement membrane in membranous glomerulonephritis. And in electron microscopy, we can again see variable sized deposits, okay, and of variable shapes also. These deposits here looks black, dark gray in color, while the basement membrane material looks the light gray in color. Now, another glomerulonephritis that we are going to talk about that is actually a severe form of glomerulonephritis, and it's called rapid progressive glomerulonephritis. Why it's rapid? Because within few days or within few hours, it will lead to progressive acute renal failure, okay? So that's why it's called rapid progressive glomerulonephritis. The other name for it is crescentic glomerulonephritis. Why crescentic? Because under a microscopy, we can see crescents within the glomerulus. مرة ثانية اطفوا موبايلاتكم وضبوهم الكل يلا. لا ضبوهم بالشنطة، ما بدي أشوف موبايلات على الطاولة. So we call them crescents because under microscopy we can see cellular crescent formation. Crescents, they are semilunar in shape, and they are masses of proliferating cells. What's the type of this cell here? Yes, it's the parietal epithelial cells of the Bowman's capsule. Okay, so here the Bowman's capsule epithelial cells start to proliferate and to give us this mass, crescent shaped mass. And here, if you look at the glomerulus, it's being compressed in the center and pushed to the middle. So it's compressing the glomerulus here and leads to acute renal failure. So if you see a crescent, this is a bad sign, and this patient is undergoing acute renal failure and acutely into end-stage renal disease. Now, this crescentic glomerulonephritis can be caused by many other causes, other diseases like lupus nephritis, like post-infectious glomerulonephritis. So other glomerulonephritis may lead to crescentic glomerulonephritis. Sometimes vasculitis, small vessel vasculitis may lead to crescentic glomerulonephritis. Sometimes disease called good pasture syndrome also is one of the diseases that can be complicated with crescentic glomerulonephritis. So most of the time it's secondary to underlying disease. This is another epithelial crescent. We call them epithelial because the proliferating cells are the epithelial cells of the Bowman's capsule. And here they are compressing the glomerulus in the center. Now we said one of the causes is good pasture syndrome. Who knows what's good pasture syndrome?
Antibody against collagen.
Yes, it's an autoimmune disease. These patients having antibody against glomerular basement membrane. As you know, the glomerular basement membrane contains type 4 collagen, so it's against one part of the structure of collagen type 4. And it's actually this antibody is bound to the glomerular basement membrane of the kidney, but most of the time also to the basement membrane of the lung. So most of them, they will have also lung symptoms of shortness of breath, chest pain, hemoptysis, coughing blood, okay? In addition to hematuria, proteinuria, and other features of kidney problem. So this is the good pasture syndrome. Secondary, the patients may also have crescentic glomerulonephritis and rapid progressive glomerulonephritis. Now, to highlight the crescent, we can do an antibody to fibrinogen under immunofluorescence. Fibrinogen is actually protein is found in blood, and because it's lost in crescentic glomerulonephritis, it's entrapped within the crescent, and here it's positive. If we check for it in immunofluorescent microscopy, we can see there is positivity within the crescent for this fibrinogen protein. And actually, fibrinogen was one of the initial particles and proteins that irritate the Bowman's capsule, irritate the parietal epithelial cell, and lead to this abnormal crescentic proliferation of and crescentic formation. Now, if you look at this immunofluorescence to IgG, here we can see that is it positive or negative, first of all? It is positive because it's bright green in color. What's the type of positivity? Is it membranous or mesangial? No, we can see the capillary loops. If you can see the capillary loops, that means it is membranous, okay? So it's drawing a line along the membranes. It's a membranous positivity. The second thing, is it of a granular or linear type?
Linear.
It is linear. So it's different from what we have seen from the granular positivity. It's linear, continuous positivity of the same intensity. And this is what we see in good pasture syndrome. So this is actually diagnostic of good pasture syndrome, this linear positivity along the basement membrane because of the presence of anti-GBM antibody, anti-glomerular basement membrane antibody in good pasture patients. Now, moving back to nephrotic syndrome, we said we have nephrotic syndrome, the most common causes for nephrotic syndrome we have talked about. Now, moving to nephrotic syndrome, patients who usually present with hematuria, hypertension, azotemia, and sometimes small amount of proteinuria. Now, actually, the most common cause for nephrotic syndrome in adults, it's IgA nephropathy, okay? So, why do we call it IgA nephropathy? Because the deposits in these patients is of IgA type. It's not IgG, it's not IgM, okay? It's IgA. And mainly the deposits of IgA, if you remember, the IgA is the secretory immunoglobulin that's present in our saliva, in our secretion, upper GI, and GI and respiratory tract secretion. They are very rich in immunoglobulin A, okay? And this immunoglobulin can become entrapped within the mesangium. So if you look at this glomerulus, the pathologies are mainly where? The abnormality is mainly within the mesangial. There is mesangial cell hypercellularity, okay, or proliferation. If you look at the endothelial cells, they are normal because the capillary loops are still open, are still patent. The podocytes are normal, so the only finding is mesangial. So we have mesangial matrix deposition and we have mesangial hypercellularity. انتوا على الكمبيوتر واحد اللي بتحكوا؟ You are disturbing us. صوتكم كتير عالي. So mainly the IgA deposits are mainly within the mesangial, and so that's why mainly the mesangial cell that shows the proliferation and the mesangial matrix deposition. Now we can confirm the presence of IgA by doing immunofluorescence for IgA. Okay, so this is immunofluorescence. This is antibody for IgA, and here we can see the mesangial positivity. We don't see membranous positivity. Actually, the membranes here are negative. The capillary loops are negative. The positivity is only seen within the mesangial, and it's of granular bright green positivity. Okay, so this confirms that this is actually IgA nephropathy is the cause for nephritic syndrome in this patient. Now, another cause for nephritic syndrome, less common than IgA nephropathy, is MPGN. MPGN, membranoproliferative glomerulonephritis. Actually, you will hear that we have MPGN type 1 and MPGN type 2. But actually, they are completely separate disease. MPGN type 1 is a completely different disease from MPGN type 2, okay? So the other name for MPGN type 2, it's also called dense deposit disease. First of all, we are going to talk about MPGN type 1 mainly. So in MPGN type 1, it's called membranoproliferative glomerulonephritis. So the pathologies are seen within the membranes and proliferation. So there is abnormal membranes and abnormal proliferation of cells. If you look here at this glomerulus, you can see the proliferation. The hypercellularity, we have mesangial hypercellularity, endothelial cell hypercellularity, because most of the capillary loops are occluded, and we have epithelial cell podocyte hypercellularity. So that's why it's called proliferative glomerulonephritis. If we want to look at the membranes, we said one of the good special stains is what? A silver stain. So this is the silver stain here in MPGN type 1 disease, and here we are going to look at the membranes. We said it should be just a single continuous line, black line, but if you look here, what do you notice? Double lining. It's instead of one line, we have two basement membranes. We have two lines. That's why we call it double contouring or tram tracking, because it resembles the track of a tram. Double contouring or tram tracking is seen in MPGN type 1 because of splitting and new membrane formation at the glomerular basement membrane. So under electron microscopy, we can see the old basement membrane. This is at the bottom. This is the old basement membrane. And here we have splitting. At the site of splitting, we have mesangial cell. This is the nucleus of mesangial cell and cytoplasm of mesangial cell that initially was part of the splitting of the basement membrane. And here on top, we have a new basement membrane formation. So that's why we have a duplication or double contour appearance or tram track appearance of basement membrane in MPGN type 1. Now in type 2, this is electron microscopy for type 2. Type 2 is also called dense deposit disease. In type 2, we don't see double contouring, we don't see tram tracking, okay? So it's completely different disease. What we see is dense deposits. That's why it's called dense deposit disease. We have massive dense deposits within the basement membrane that actually later on they will fuse together and form a ribbon-like mass within the basement membrane. It will give us a ribbon. These deposits are actually formed due to antibody to C3 nephritic factor. So the antibody here is to C3 nephritic factor deposits within the basement membrane in type 2 MPGN. This is C3 positivity. Here we can see it, the ribbon-like appearance under IF. It's continuous and it's membranous positivity for C3 antibody. And if we do the blood test for them, we can also see the C3 nephritic factor in their blood as well. Now shortly we are going to talk about lupus nephritis. we call it lupus nephritis because it occurs in SLE patients, systemic lupus erythematosus patients. They are frequently, they have complication and glomerulopathies that lead mostly to nephritic syndrome. So they have features of hypertension, hematuria, some level of proteinuria. And in lupus nephritis, we have immune complex deposits along the capillary loops, and that they give them this thickening, massive thickening of the capillary loops, that the capillary loops became resembling a wire. That's why we call them wire looping. So we have wire loops in lupus nephritis. Now they have different stages according to the severity of lupus nephritis. And later on they may also have hypercellularity, and even sometimes they can be complicated with crescentic glomerulonephritis and rapid progressive glomerulonephritis. Because they have nephritic syndrome, we expect that their urine analysis will show proteinuria in addition to hematuria. We can see RBCs in their urine analysis, microscopic urine analysis. Sometimes we can see casts, granular casts and tubular casts. Now, do you have any question regarding glomerulopathies or cystic kidney diseases? Okay, thank you.